就是由王俊杰教授来主持下一个题目啊。王俊杰教授是三峡大学附属人科医院主任医师、副教授医学博士、博士生导师，三峡大学附属人科医院妇产科主任，微创医学研究中心的常务副主任、妇科肿瘤研究所的所长等等，非常多的这个行政兼认可的学术地位，有请。
Good afternoon, everybody. Good afternoon to all professors. Good afternoon to all my colleagues from all over China, especially Sichuan province. My deepest greetings to ISMIVS committee for inviting me to this excellent meeting in the lovely city of Suining. Thank you very much for the hospitality. For us, for the Indonesian team, we really have a good time. We have done some exercise this morning and also hospitality of Dr. Chen having hospital tour of the Suining hospital. This is just like becoming an army because we have done a lot of exercise, we have done a lot of working. So thank you very much for your time, Dr. Chen. And for my topic this afternoon, is hysteroscopic management for acute massive vaginal bleeding after HIFU treatment for fibroid. The reason why I chose this topic because
Excuse me, Dr. Sigit Pramono, please let me introduce your topic to the audience.
Oh yes. Oh yes. So
下一位讲者呢是来自印度尼西亚的Sigit Pramono 医生，他的这个讲题是子宫腺疾病海服术后急性阴道大出血的宫腔镜治疗。Sigit 医生来自阿布迪布罗瓦医院。那么接下来呢，就让我们聆听他的讲座。
Thank you very much for the introduction, Doctor. Thank you very much. So the topic this afternoon is hysteroscopic management for acute massive vaginal bleeding after HIFU treatment for fibroid. The reason why I chose this topic because I was searching on the internet, not much literature about acute massive vaginal bleeding. So that's the reason why I chose this topic. So hopefully I like to share my experience and get some input from the expert because I like to prevent it happening again in the future. So we have Mrs. B, she's 29 years old, no baby, no pregnancy before, has primary infertility for 2 years, and she has been complaining of heavy, painful menstrual bleeding since childhood. And basically she does have deep dyspareunia as well. So since marriage, they haven't been able to have intercourse, unfortunately, because it's so painful. So we have done the MRI, and the MRI showed that she does have a massive intramural fibroid or adenomyosis. I just like to try to show where the uterine cavity. The uterine cavity is being pushed up there on the right side. So the mass itself is about 20 weeks pregnant. So this is the coronal view. I just like to show this is the uterine cavity. This is the uterine cavity. This is the sagittal view. Again, this is the uterine cavity pushed up high at the top of the uterus. So also the mass occupies the whole pelvis. So when I examine, basically there's no mobility, and also it's so painful on palpation. Surprisingly, her hemoglobin is about 12. So we discussed about HIFU treatment. Definitely, medically she has no children, planning to have children. We try to avoid to do unnecessary surgery. I don't think from the surgical point of view we can remove this mass. It's impossible. So we discussed about HIFU and the family agreed for HIFU treatment. So HIFU treatment, she underwent HIFU treatment, and we started at the biggest slice and the back posteriorly. We pay attention closely to the radiating pain because, as we can see, the biggest slice very close to the sacrum. But the patient tolerating really well with minimal intravenous sedation. As we can see, grade changes started at sonication time 297. So we continue to ablate the whole mass. And she was tolerating really well. The tissue responded really well. We can see the whole grade changes for the whole intramural fibroid. So we completed the treatment at sonication time 1442. We can see for the mass there is no blood flow on Doppler ultrasound. So the total energy we give 572 150 joule, sonication time 1442 seconds. She did tolerate really well with minimal pain at that time. So we performed the MRI day 1 post HIFU treatment. In that morning, so she had the treatment about 9 o'clock in the morning, and then she had MRI done the following day around the morning as well. When she came down to the MRI, she suddenly developed abdominal pain. She was complaining the pain was more than before the HIFU treatment. As we can see from the MRI, she does have a nice necrosis coagulation consistent with the HIFU treatment, but what we didn't like is the swelling, and she did complain a lot as well, more backache and also abdominal pain. She was complaining that the tummy size is bigger compared to before treatment, and we believe she may have a little bit of bleeding into the myometrium as well. So she couldn't go home day 1 post HIFU, so she stayed a little bit longer. We continue to give intravenous painkiller, paracetamol, and also antibiotic. And she got better day 3 after HIFU treatment. But just about, she was about to go home, discharged from the hospital, she suddenly had a massive abdominal pain and massive vaginal bleeding. We estimated she lost about 2 liters of fresh blood vaginally, and her blood pressure dropped to 60/70. Hemoglobin dropped from 12 to 6. So the patient basically became hypothalamic shock, and we rushed the patients to the theater. So code blue was announced, resuscitation started. Now, I was thinking at that time, what am I going to do in the operating theater? Luckily, I was able to do abdominal scan before she went to the theater. On examination, her tummy abdominal skin is soft, but the uterus is so painful and it's very tender on palpation, and it's bigger compared to before HIFU treatment. So I thought she wasn't bleeding internally. So when I was taking the patient to the theater, I was thinking, what am I going to do in the theater? Am I going to do laparoscopy to see what's going on? Am I going to do laparotomy, or am I going to do hysteroscopy? Because the main issue is bleeding vaginally. I think definitely laparoscopy is big no, because it's hemodynamically not stable. Laparotomy is a question mark as well for me, because what am I going to do? Am I going to do myomectomy? Am I going to do hysterectomy? Or am I going to do internal ligation? I think would be so difficult as well to do hysterectomy, because the mass itself occupies the whole pelvis. So when we go to the theater, I was thinking, if I perform laparotomy, then I may have to do modified delinge to stop the bleeding. That's what I was thinking if I have to do a laparotomy. And I was thinking, if I'm doing hysteroscopy, then I need to put something to tamponate and stop the bleeding. So by the time she got to the theater, she was bleeding profusely, heavily from the vagina. That's the reason why I performed hysteroscopy. So hoping that I could stop the bleeding. Now, interestingly, what I find during hysteroscopy, she does have elongated long cervix. She does have elongated long cervix consistent with the MRI finding. She does have a nice uterine cavity above, and we could identify the internal os as well. And she's bleeding a lot along the canal of the cervix of the left side of the patient. So very, very interesting. I just show you again. So this is what I found. So she may have a small intra-cavity fibroid, but above that, that's the internal os. Above that is the uterine cavity consistent with the MRI finding. Along downside, so towards the cervix, there's a lot of massive bleeding, the necrotic tissue from here. So, and the bleeding was from that point, from that area. So, this is, I can see the shadow, so many blood transfusion. Thanks God that we really have a good team. So some nurses putting out some blood, that's from the right side. Some other nurses putting blood transfusion from the left side. So yeah, that's the right side of the patient. So at the same time, we're giving like 6 bags of blood transfusion at the same time, and platelet as well. Because in the theater, I thought we are going to lose the patient. So you can see here now. So this is the picture. So a lot of necrotic tissue. So that's above this. That's the uterine cavity, small. At that level, that's the internal os. This is all the necrotic tissue from the internal os down to the cervix. That's the balloon. So I decided to use the Foley catheter number 24, and I used the balloon to inflate slowly. So what I did with the hysteroscopic guided, I pushed the balloon up high, above the bleeding area, and inflate the balloon slowly. And I pulled the balloon slowly down towards the cervix. And at the same time, I'm inflating the balloon. So to stop the bleeding until I can see the bleeding is settling. So after about 10 blood transfusion in the operating theater, we stabilized the patient. The patient was observed in ICU. Unfortunately, she ended up with all the complications as the textbook. She was septic, she developed ischial nerve injury, massive blood transfusion, bilateral deep venous thrombosis, and DIC. And one thing, I continued the syntocinon infusion for 2 days to reduce the bleeding, because day 1 in ICU, I stopped the syntocinon infusion, she started to bleed. So I continued the syntocinon for 2 days in ICU. So we can see after a week in ICU, after multidisciplinary approach, I'm glad that we have a good team in our hospital. She was fully recovered. Thanks God for that. And by that time, she was still having a lot of ischial nerve damage. She wasn't able to walk. So in ICU, we gave her high dose of steroid as well and Meticoba as well. So I just like to share my experience because it was a frightening experience. I know the HIFU itself went really well. We were quite satisfied with the grade changes. So I just have some thought about this case. From the hysteroscopy, along the way, I find that the mass itself is along the cervix or the cervical canal. We thought, discussing with the radiologist, we thought it was in the body of the uterus. But from the hysteroscopy, I believe that's along the cervix because that's along the cervical canal. Because consistent with the finding of the MRI that the uterine cavity pushed up high. It's just my theory. So the question, we know that cervix has more connective tissue compared to myometry. So I suspect the necrotic coagulation caused more bleeding in the cervical canal compared to the body of the uterus. That's what I was thinking. I don't think with that size, 14x11, sonication time 1400 is too much for that size of the mass. It's just I'm thinking because we're treating the canal, not the body of the uterus. That's why, because cervix has more connective tissue than myometrium. Maybe the necrotic coagulation caused massive bleeding compared to myometrium. That's just what I was thinking. So, and the other things what I learned that hysteroscopic guided intrauterine tamponade is effective and safe. And the next question, whether in this case, if we do have another case like this, that the cavity is being pushed up high, do we need to perform hysteroscopy first before we do the HIFU? My next things that I think all gynecologists do not forget to do the old-fashioned of operative hysteroscopy. That I think we need to learn, we still have to do the old-fashioned operative hysteroscopy using scissors and grasper. I know these days on the market there are so many hysteroscopic morcellator. For me, it makes me lazy because there's no coordination between the right and left hand. I think if I wasn't trained well to do operative hysteroscopy, I wouldn't have known what to do at that time. So I think I learned a lot when I was a trainee. The other things what I want to know, getting input from the audience. If we see MRI post HIFU with that kind of swelling, massive swelling, more pain, and also possibility of bleeding into the myometrium, do we need to get the patient to stay a little bit longer, just for precaution? Yeah. And the other things, if we are dealing with difficult case, I think next time I will warn my interventional radiologist. But I guess not sure how quick they can do the internal iliac embolization. So, but I still love HIFU ablation. This is 3 months after treatment. As we can see, she's having regular period and she does have a nice normal uterus. It's amazing result. I think she's a tough person and she got supported from the family. We really like it after 3 months post treatment that she does have a normal uterine size and she's having regular period. So we can see this is pre-treatment. This is day 1 post-HIFU treatment, the MRI. And this is 3 months post-HIFU. The patient and the family is extremely happy with the result of the HIFU ablation. But as a clinician, I'm just a bit scared now to do if we are dealing with another massive vaginal bleeding. So I think what I learned from this case is basically if we have to think, if we are dealing with a massive mass, I think we try to avoid laparotomy. Laparotomy is not always the answer. I think it's going to be very difficult to do the internal iliac ligation with this mass, and also to perform hysterectomy. Even though if we have to do subtotal, I was thinking to do subtotal hysterectomy, I think it will be so difficult as well to clamp and to stop the bleeding. And don't forget our friend, interventional radiologist. And the other things now, what I'm looking at the MRI, am I treating body of the uterus or am I treating the cervical area? So that's what always back in my mind. And the other things, should we do office hysteroscopy? If we can see like the uterus, the uterine cavity is pushed up high. So it means that we are dealing with very long elongated cervix. Thank you. 谢谢.
Thanks for Dr. Pramono. Dr. Pramono shared interesting and valuable case of complication after HIFU ablation, massive vaginal bleeding. Thank you very much. I think your experience is very valuable and useful for us. And I have two questions for you. The first one, I wonder, in your mind, what's the reason, what caused the vaginal bleeding after ablation for this case, for this patient? And second question, if I were you, maybe I will choose iliac artery embolism or uterus artery embolism, because so much vaginal bleeding, so much uterus bleeding, I'm afraid I can't see the uterus cavity clearly under hysteroscopy, and I can't treat the problem under hysteroscopy. So maybe I will choose embolism. What do you think of it? Thank you.
Thank you, doctor. Thank you, moderator. Yeah, so I was lucky. Before I was taking the patient to the theater, I was able to do bedside ultrasound. And from examination, I couldn't see any free fluid. That's the only reason why there's no point to do laparotomy, unless she was bleeding internally. I guess I was just so lucky because at that time, the blood pressure was only 60 over 40 on palpation. She just collapsed. But I was able, because I was thinking, if I have to do laparotomy, what am I going to do? Because on examination itself, the mass itself is not mobile. Then it was good. When I was learning with Dr. Howe was with us for 3 months. He always tell me, remember where the uterine cavity is. Just remember. I didn't know what he meant. Well, I mean, now I find out that's really important because for me, that's the landmark. Because the patient, no children, married for 2 years, so that's why I like to preserve, as an IVF specialist, I like to preserve the uterine cavity. Because yesterday there was a question about how small, how big is the uterine cavity good for the embryo transfer. So that's why for me, I always think I want to make the anatomy as good as normal for the uterine cavity. So that's the reason why I didn't do laparotomy. So I remember from the MRI, it was up high. And by the time she got to the theater, the main issue is bleeding vaginally, massive. So when we put the patient on lithotomy position, still the same bleeding vaginally. Even though we try to tamponate into the vagina, the bleeding didn't stop. So that's the reason why I decided to do hysteroscopy. I just didn't know. I thought no bleeding internally, big mess, no point to do laparotomy. So I just decided, just put the telescope, the hysteroscope, and that's what I found. I guess I was lucky. This is what I guess I was lucky. Because this is what I find, that basically I could identify the bleeding source. That's the reason why. So that's the cavity, and she was bleeding massively along the cervix. So so that's on the right side. Underneath that all the necrotic tissue. So that's the reason why I was happy I could find the bleeding source.
Sometimes we can't see it.
Yes, so behind underneath, that's the start. This is the start of the necrotic tissue, all bleeding. So this one towards the cervix. So the hysteroscope, I went about 15 centimeters. So the whole hysteroscope went in. The whole scope went in. So this is just like halfway. This is just halfway of the hysteroscope. And so underneath this, more necrotic tissue, more massive bleeding. So because at that time, the video wasn't that clear because of the massive bleeding. So I took picture of the balloon. This is the necrotic tissue. This is the necrotic tissue. That's the necrotic tissue. So this one is above. This one is more to the head side, to the fundus. This one is roughly about mid of the cervix down to the external os. This one. And down there, more necrotic tissue. That's the reason why I put the balloon underneath. So that's the reason why I put the balloon high, inflate the Foley catheter balloon about 50 to 100 cc. I know that the Foley catheter only occupies 25 to 30, but I need to occupy the whole canal of the cervix. And I bring it down slowly until to the necrotic tissue and stop the bleeding. So this is the area of the necrotic tissue after I tamponate there. This blood clot, this is all necrotic tissue. All necrotic tissue. So that's the balloon. So I can see once I inflate the balloon, the bleeding settles bit by bit. But of course, with resuscitation, we give blood transfusion, we give fresh blood, we give everything, and as a massive blood transfusion. So this is all the necrotic tissue.
Okay. Thank you very much.
My pleasure. Thank you. Session.
下一位。